Hello everyone, you're watching sqadia.com and we are dealing with metabolic bone disorders. Now we'll be going through one of the very important cause of metabolic bone disease called as renal osteodystrophy or chronic kidney disease associated renal bone disorder. In this, we'll be going through the pathology, the clinical features, x-rays and treatment of chronic kidney disease, especially if it is causing bone disorders. So what actually happens if you see in our body, parathyroid gland releases parathyroid hormone. It not only increases calcium deposition in the bone, which can affect the parathyroid hormone gland activity reciprocally via negative feedback. Similarly, it also causes increased absorption of calcium and phosphate from the gut, as well as increased calcium reabsorption from the kidneys. Now if something is wrong over here, then there is not enough calcium reabsorption would occur, leading to there will be far less calcium present for the bones to incorporate. Overall, although the parathyroid gland is normal, but as there is negative loop is actually broken because there is not enough calcium reabsorption, this results in renal osteodystrophy, that eventually the calcium is lost in the urine. Eventually not enough calcium is present for the bones to incorporate, leading to decreased bone mass and basically weaker bones. Skeletal and soft tissue abnormalities, there are associated with this, called as renal osteodystrophy, because this is actually that enough calcium is not absorbed from the kidneys, therefore leading to osteodystrophy. If you see the histopathologically, this could be osteoblast function is impaired due to systemic consequences of chronic kidney disease, including acidosis and increased sclerostin levels. Despite defective osteoblast function at a cellular level, bone turnover is generally increased in part due to higher fibroblast growth factor 23 levels. Now, in a normal human body, if there is decreased activity of osteoblasts, definitely there would be decreased activity of osteoclast as well. And in any case, if osteoclast activity has increased, there will be definitely some degree of increase in osteoblastic activity. But if that osteoblastic activity is high enough to maintain a kind of homeostasis, that if the bone is resorbed from one end, that can be absorbed, laid down again from the other side. But if that balance is actually affected, if for any reason either the osteoblasts are effective or osteoclasts are defective, this which eventually results in a metabolic bone disorders. And same is the case over here in chronic kidney disease. Number one, there is not enough calcium absorption. There is not enough calcium present in the blood so that it can be incorporated into the bone. The second problem is actually the defective osteoblasts, that even if there is some degree of calcium, that is not properly been incorporated into bone so that the bone mineralization can progress at a normal speed. Pathologically, it's a high turnover disease. It's actually can be differentiated into high turnover and low turnover. If calcium is not absorbed back into the blood, this would cause by a negative feedback loop. This would be sensed by the blood in the parathyroid gland, and this would result in further increased production of parathyroid hormone. Usually in case of high turnover disease, this is presented with low calcium, high urinary calcium and with hyperparathyroidism. But sometimes it's an adynamic bone disease as well, that although there is not enough calcium is absorbed, there is hypocalcemia in the blood and there is hypercalciuria, but the parathyroid hormones are normal. They are not resulting in concomitantly increased secretion of parathyroid hormone, so that the absorption of the calcium can be increased. Then if there's less amount of calcium present, there is associated osteoblastic problem as well. Therefore, there is defective mineralization and decreased mineralization in the bone. Clinical features include there's usually increased fracture risk, hypogonadism and glucocorticoid therapy. There may be history of glucocorticoid therapy. There may be history of growth retardation. The patient may present with slip capital femoral epiphysis. A child of usually adolescent age comes with slip capital femoral epiphysis. This is usually associated with hypothyroidism. and this hypothyroidism or metabolic disorders eventually results in are associated with osteodystrophy as well. There may be vascular calcification, which may be seen in patients with renal osteodystrophy, and hypertension and increased cardiovascular mortality as well. There may be associated hormonal disorders which may cause hypertension and cardiovascular mortality. You see on these x-rays, if there are paper thin cortices especially, and this decreased amount of bone mass, that is showing osteopenia, especially in case of patients with chronic kidney disease as compared to the normal hand. Treatment: restricting the intake of phosphorus and taking phosphate binders. Why we need to restrict them? Because usually calcium is not properly absorbed and it's released in the urine, resulting in hypophosphatemia, which results in increased phosphorus levels in the blood, which further actually decreases the absorption of calcium. Administering a vitamin D analog. Why this is given? Because vitamin D results in increased absorption of calcium from the gut, so that the bone mineralization can progress at normal rate. Calcium sensing receptor agonists are given. Why? Because they increase the amount of calcium absorption. Oral bisphosphonates are also helpful because they increase the bone mass or bone mineral density, which is therefore the mineralization of the bone is actually affected. We have just discussed that renal osteodystrophy is one of the rare causes, but a very important important disease in patients, especially who are having long-term diabetes or who are on long-term steroid use, especially in case who have end-stage renal disease, because the effect of parathyroid hormone, the kidney, to cause increased absorption of the calcium, which may be defective in these patients, may result eventually in low bone mass and bone turnover, leading to osteoporosis and fragility fractures. Thank you very much. Keep watching sqadia.com.